I think it's a really important question what I'm going to speak about next, which is how much radiation do we need to give? And if we're using hormonal therapy, now we're talking about intermediate and high-risk patients, what's the break point between the advantages of hormonal therapy when you raise the dose of radiation? And can we get rid of some of the hormonal therapy or all of the hormonal therapy? And what's the data show? So that's what we're going to get into. Skip that. So benefit of androgen deprivation with high biological effective dose. Dr. Stock has just explained what all that means. Long versus short-term ADT when men receive external beam radiation. What's the testosterone recovery look like after hormone therapy and radiation? Because that's the price patients will pay. And we'll talk about the recently published TRIP study. So Dr. Stock showed these calculations, but what I'd like to say, and I think, Richard, this would be very helpful, is it doesn't help to put up data and say, well, this patient got HDR 3 fractions at 5 gray per fraction, or he got higher doses at lower fractions of external beam radiation without putting up the BED, because you can't really figure it out in your head. So I put these up, Dr. Stock put them up, but I'm going to reinforce it, and then when I show you some of the data, I'm going to always have the BED there up with the actual physical dose, so you understand when you compare things, we're talking about the same numbers. Because 70 gray of external beam, what does that mean in terms of an iodine implant? So here it is. 70 gray is 133 of external beam. Today, we typically deliver 81 gray and 1.8 gray fractions, and that's 154 gray in a BED. And that's the same, basically, as an iodine implant of 145, which is what the current ABS recommendations are for iodine implant. At Mount Sinai, our typical iodine implant has a D90 of 189, and that's equal to a BED of 200 gray. So we are routinely delivering our patients who have intermediate risk disease, because we don't treat low risk anymore, or not many of them, they're typically getting at least 200 gray as a BED. If you're delivering combination therapy, the typical dose is 45 gray of external beam and 110 gray of iodine, and that's got a similar BED as our monotherapy. It's 200 gray. But if you deliver a D90 of 130, that kicks it up to 220 gray. Now, keep in mind, these are post-implant doses. These are not planning doses. You know, it's amazing to me that we get a lot of publications in the literature on brachytherapy, and you rarely, if ever, see anybody reporting their post-implant dosimetry data. And even in the Ascendi trial, which had a lot of complications, grade 3 complications were 15, 17%, and their planning doses were this. But we have no idea what was delivered. And I'll show you some data as what happens when you look at the individual data from multi-center trials. So Richard and I got interested in looking at the effects of hormonal therapy and dosing, and this is a paper we published, I think it was 12 years ago. And first we said, okay, what does it look like? What does it look like if we give our patients hormonal therapy plus brachy or we don't? And you see the advantage of hormonal therapy there. And then we said, what about if we divide the doses and we separate the patients by higher dose versus lower dose? And the dose we chose was 150, because 150, as I just said, was equal to roughly the amount of dose that ABS was recommending. That's why we chose that cut point. And you saw that the curves were closer, but still hormonal therapy had an advantage. So then we started taking a look at the data in these risk categories, and we then chose the 200 gray because we realized most of our patients are now getting a D90 of 189, which is a BED of 200, and for those men who received an implant with a BED less than 200 gray versus more than 200 gray, you could see the patients with lower doses, the use of hormonal therapy was the only significant variable. But if they got more than 200 gray, then hormonal therapy no longer was a significant variable in predicting biochemical failure, and most importantly, biopsy results. So we all should recognize that men who get treated for prostate cancer, whether it's intermediate or high risk, and they're getting radiation therapy or radical prostatectomy, the primary avenue of failure is local. Local failure, which means we don't do a good job of treating the disease when we're looking at localized prostate cancer. That's one of the reasons why when I set up the protocol at Sinai in 1990 we started. And coming out of Memorial as a surgical urologic oncologist, I made it a priority to treat these patients as if they were getting radical prostatectomy. That meant every patient who got an implant in the early days had a node dissection, initially open, then laparoscopic, and every patient of mine, unless they didn't agree as part of the protocol, got 2-year post-implant biopsies. So we have a huge amount of data on what the effects of the radiation dose is regarding local control. And this is going to become increasingly more important, as I'll talk about later when we discuss focal therapy. So we decided we were going to divide these into 3 different bins, 150, 150 to 200, and 200 gray. And you can see, didn't matter what risk group you were in, the higher the dose, the less likely you were going to have local failure. Now, how does this translate into external beam? Because today, most patients don't get brachy if they're getting radiation. They get some form of external beam. And it's very easy to calculate out the dose, whether it's a hypofractionated dose or a standard dose, into the BED. So you look at all these studies, and I put in parentheses here the BED. You can see the BED of all these randomized studies. They're around 130 to 140, pretty low. But yet, when you look at the hormonal therapy, 0 versus 3 years, 6 months versus 36 years, and you look at the red, you see almost every study has an advantage to adding hormonal therapy. So from a wealth of data that's been published over the last 20 years, plus it's become standard of care when you're treating a high-risk patient with external beam radiation to give 2 years of hormonal therapy. And that has not changed in a long time, and it should change, and I'll show you why. Here's some data, several studies, one that includes HDR, so that was the highest dose. The left side of the forest plot favors longer-term hormonal therapy, 18 months versus 6 months on the right. And here is the radiation dose escalation. So even when you get up to HDR, and here's the HDR schedule, it was combination with external beam and 2 fractions at 6.5 times 3, which has a BED of 176. So remember I talked about 200 being the cut point. So even at this higher dose represented here, you still see the advantage of 18 months of hormonal therapy. So now you're starting to get some idea here is 175 or so is not enough to lower the dose of hormonal therapy. This is 18 months versus 6 months. Okay, what's the price that we pay when we give hormonal therapy? So we've had a lot of patients with hormonal therapy, and when you look at the group, so no hormones, 6 months or less, more than 6 months of hormonal therapy, you see that age is a variable. So these are the entry criteria. So older patients get more hormonal therapy because, and they have more diabetes, older patients, make sense, and because the reason why they're in this category, because most of them have higher risk disease, and so they're getting more combination therapy than brachytherapy. So you have all these mixed variables, so you need to do multivariate analysis to see which really is important when you have these mixed groups of patients. And the last testosterone level 2, and these are post-treatment, is higher in the patients who got monotherapy than combination therapy because the ones who are getting combination therapy are getting the hormonal therapy. So it all makes sense. So look at the multivariate analysis, what sticks. This is for persistent hypogonadism, testosterone less than 300. What was important was the age of the patient and whether or not they had diabetes. Those are important variables. So how do you use that data? Well, if I'm going to give a patient hormonal therapy and I'm going to give it longer, I know that older patients and those with diabetes are less likely to recover. And what about castrate? And also, this is interesting. This first time we published this, that men who got external beam radiation versus brachytherapy, when you're looking at it in a multivariable analysis, that was also important. So there may be some scatter to the testicles, which is causing the decrease in testicular function. That really needs to be looked at more carefully. And the number of months on continuous hormonal therapy. So the hazard ratio here is 4, which means every month longer you give the hormonal therapy, there's a 4% greater likelihood that patient's going to end up with hypogonadism. Now, when you look at castrate levels, testosterone less than 50, the only thing that was significant was the length of time of hormonal therapy. And the hazard ratio is 9, which means for every additional 9 months, every additional month, there's a 9% greater likelihood of getting a patient having castrate levels of testosterone. Here's a study that looked at neoadjuvant deprivation men treated with brachytherapy, and they subdivided the men into 36 months or longer versus 3 to 12 months, so 2 groups, and they saw how they did in terms of recovery. And what they found in this study was, here's the multivariate, the age again, significant, and the testosterone level at baseline, significant. So here's another variable. We didn't really routinely do this when we were first starting our program, but it probably is a good idea to measure the man's testosterone level before you start treatment. Because if he ends up with permanent hypogonadism and he didn't know he had a low testosterone to begin with, he may blame you. So let's figure this out, and then you can put this in your informed discussion with him. Mister, you've got a low testosterone, your risk of recovering your testosterone, especially if we're using 2 years of hormonal therapy, is going to be less likely because your testosterone is low. There's another study that looked at androgen deprivation following radiation therapy, and you can see what sticks here is duration of ATT and baseline testosterone. Same story. Here's a Japanese study comparing 6 months of ADT to no hormonal therapy. What's significant? Again, only here it's this one, the use of an agonist. That's the first time I've seen that. The BMI. So now you're starting to see data similar to diabetes, I think, that men with high BMI are less likely to recover their testosterone. So it's another variable. Sir, you're got a BMI of greater than 30. Your likelihood of recovering your testosterone after ADT is going to be compromised. So let's talk about the TRIP study. And there's a lot of important things I want to go over here with you. This was a study of high-risk prostate cancer with one or more of the following features: Gleason 8 or greater, PSA greater than 20, or clinical stage T2C, T3A. And you can see the entry variables there. So this was a study that was conducted solely in Japan, started in 2012, in 37 centers. I trained every one of these teams on brachytherapy and combination therapy, and I'll go over why that has, I think, very important implications. The major places were in Tokyo, Nagoya, and in Osaka. We had centers up here in Hokkaido and Sapporo, and we had one center way down here in Okinawa and Naha. The study design was high-risk prostate cancer, 1-to-1 randomization, and it was everybody got 6 months of hormonal therapy at entry, then the patients were randomized to no more hormonal therapy versus another 24 months. So it's 6 versus 30 months of hormonal therapy. The study was designed as a combination implant first, 110 gray was the planning dose, and then 45 gray and 25 gray fractions following the implant with a 1-month break. So when you do these type of studies, when you're giving just external beam and you're doing a randomized study, you know the dose of everybody. It's the same dose, it's 70 gray, 75 gray. That's not true when you're doing an implant, because the dose delivered, The dose prescribed is the same, but the dose delivered is different because the seeds don't end up exactly where you think they're going to end up. And we know this, brachytherapists know this for a long period of time. So the problem with randomized studies when you're doing brachytherapy is that you could have a bias because some patients could have a much higher dose delivered than other patients. And if that becomes a variable, it's going to pollute your study and you're not going to be able to make sense of this. So it was very important to standardize the dose delivered. So what we put into the protocol, and this took a lot of discussion, was that if the D90 was substantial, the post-implant D90, based on the post-implant dosimetry, not the prescription dose, was substantially lower or higher than 110 gray, we allowed the centers to adjust the external beam dose so the final BED was going to be as close to 220 as possible. And we set safety criteria in, which was if you had a lower dose, you wouldn't want to give more external beam radiation if the rectum received too much or the urethra received too much, because we didn't want to add extra radiation in and cause complications. So I tightly controlled the dose delivery in the protocol to try and keep the doses between 200 and 240 gray. So lo and behold, the median dose delivered in both arms was 217, which is pretty amazing considering you're dealing with 37 centers. So here's the other thing that's important. When we set the study up, it was set up as a superiority study. So the investigators who started the study believed that 3 years of hormonal therapy was going to confer a 12.5% benefit over 6 months of hormonal therapy. Because that's what the literature showed. And I argued and argued. I said, no, it's not going to happen. But they said, we're going with the literature showed. So it's a superiority study. Unfortunately, it should have been a non-inferiority study, which means that 6 months is not inferior to 3 years, but they did a superiority study. They wanted to accrue 340 patients. They accrued 349, so they met their accrual goals, and these are the secondary endpoints. So here's all the data on the short arm and long arm regarding radiation. It's all the same, no matter what. But the bottom line here is right above the red. This is very interesting. How much external beam was given? So now the patients have had their implant. They've had the post-implant dosimetry. Now they're getting external beam. How many patients had an adjustment of the dose? So only 3 patients in each arm had to give more radiation, which means they did pretty good implants. On the other hand, 25 patients, 12 in one arm and 13 in the other, they had to lower the dose. So when you talk about the Ascendi trial, where there was no dose control that was published, and you have a high grade 3 complication rate, who knows what those patients got? So 25 out of the 332 patients, so 8% of the patients got too much radiation. That means more than 240 gray would have been, if they had gotten 45 gray on top of their implant, they would have received more than 240, which is too high. So there was a substantial dose lowering because of the controls we put in. And that ended up, as I said, with a BED exactly the same in 2 arms. So we removed the radiation dose as a variable and our ability to interpret the results. So in the follow-up, there was no difference in follow-up time, in death, in progression, biochemical or clinical, and the use of salvage ADT, same exactly in both arms. There are the curves. These are biochemical control by Phoenix definition, no difference. At 9 years, 10% failing versus 9.5. Now, high-risk patients. More patients had 2 or 3 high-risk features than 1 feature, but a little more than 50%, and overall survival, 86, 87%, no difference in the 2 arms. The median PSA level of patients after 7 years was the same, 0.03. The number of non-relapsed patients with a PSA that was undetectable was 88 and 87 in both arms, no difference. The short arm recovered testosterone to greater than 50 castrate levels after 6 years at a greater number than the long arm, no surprise based on the other data I showed you. And testosterone recovery was significantly faster in the shorter arm versus the longer arm. No surprise based on the other data I showed you. Now, this is what I think we need to pay attention to because it has huge implications. You know, when the Ascend-RT trial came out, it scared people away from using combination therapy. Look at the grade 3. So short arm, radiation-related, 1.2%. And in the long arm, 0.6%. So you add the two together, that's 1.8%. So the grade 3 complications is less than 1% with combination therapy. So this should dispel the concern, but the caveat here is you need to do the implant right, and I still firmly believe that the implant should be done first so you can adjust the external beam dose if you're too hot or too low. So in conclusion, delivered radiation dose may be the single most important factor influencing freedom from progression and local control. Longer use of ADT, older age, higher BMI, low initial testosterone are associated with this decreased recovery of testosterone, and these factors should be discussed with patients when you're putting them on ADT. This TRIP study suggests that 6 months of ADT may be adequate as long as a sufficiently high BED is delivered. Thank you.